Sir, the mic is yours.
Thank you, Debanjan, and welcome to all the faculty and delegates for this webinar, which is a part of the series of webinars that we are having on planning concepts for important subsites. Now, it is important again to reiterate why this webinar is different from the other courses or webinars we have, because number one, we are being facilitated immensely by the presence of radiologists who are actually showing us practically the important ticks and trips of contouring, especially in they are doing this together with a radiation oncologist. So it's basically a team, and that is how it should be. That should help the residents immensely. And secondly, we are also focusing on certain aspects, not only of 3D planning, but also 2D planning and how the things have evolved from 2D to 3D in different subsites. So it gives me immense pleasure in welcoming today both the faculty who are there. I believe the first talk that we were going to have would be on the radiology aspect, and the faculty for today is Dr. Kaushik Nayak, who is the radiologist, and Anupam will join in as the radiation oncologist to chip in with that. And this will be followed again with a very interesting talk on conformal planning in hepatobiliary malignancies by my good friend, Dr. Shirley Lewis, who joins us from the Kasturba Medical College and Manipal Comprehensive Cancer Center, Manipal. And I think this is especially important for the residents because what we are going to discuss today, hepatobiliary cancers, this is not something that we discuss very often. And it is neither very common in our clinical practice, but nevertheless very, very important, because I think this is one of the areas where radiation oncology has increasingly had a important part to play, which was probably not the case when we were residents. So without prolonging this, I would like to thank both our faculty who are joining us today, Dr. Kaushik and Dr. Shirley, and I'd hand the program back to the Master of Ceremonies, Dr. Debanjan. Thank you.
Thank you, sir, for your kind words. Let me put forward the housekeeping announcements at the outset. Please be connected to Zoom with your full name and phone number so that individual identifications are easier. Please feel free to write down your questions in the Q&A section. I would be humbled to ask those questions on your behalf, and the lecture will be uploaded in the YouTube in due time. So don't panic if you miss something. Let's start with the first part, that is the fan favorite session per se, concerning radiological anatomy from the perspective of a radiation oncologist. Dr. Kaushik Nayak, consultant neuro and oncoradiologist, and Dr. Anupam Datta, senior consultant radiation oncologist, both from Netaji Subhash Chandra Bose Cancer Hospital, will take us through the session. Sir, please comments.
Yeah, thank you so much, Debanjan. Dr. Kaushik, are you there?
Yes.
So first of all, to all the residents and everyone who has joined us, it's very important before we go ahead with the hepatobiliary treatment planning part, we understand what exactly is important to us from our point of view radiologically. So, I have Dr. Kaushik with me, who has played an instrumental role in our institute over the last year or so in my radiation planning as well as diagnostics of hepatobiliary malignancies as well as neuroradiology. So, Dr. Kaushik, the thing is that we don't have a PowerPoint today. We need a live discussion for all our residents to understand, because this is something that we don't do very often every day during our clinical practice. Okay, so the thing is that you first have to tell me, whenever a patient with a suspected hepatobiliary pathology comes to us and we advise a CT imaging of that particular patient. So what exact sequence or what kind of CT images should we advise to a radiologist for a clear-cut initial idea of what the pathology is there?
Okay, for hepatobiliary imaging, Gold standard is triphasic CT. A normal contrast CT won't serve the purpose because different hepatic tumors have different enhancement properties, washout properties, depending which we can diagnose from them from the study. So triphasic CT is must, and also to know the arterial anatomy and all, you have to specifically write a triphasic CT scan. And please remember, triphasic CT for doing a triphasic CT scan, minimum requirement is a 16 slice scanner. Anything below 16 slice scanner will not provide good quality of images of triphasic CT scan. And that's it. Triphasic, you should write triphasic CT scan.
Okay. So if we talk about triphasic CT, I mean, what does this particular triphasic word mean to, I mean, if we want to understand from the very basic point of view?
Sure. If we write a contrast CT scan, that includes the plain CT scan without giving a intravenous contrast and a contrast scan, which is usually acquired in portal venous phase. In a triphasic scan, in addition to the portal venous phase, we specifically acquire one arterial phase for the arterial anatomy and one delayed phase. So a triphasic CT scan contains one non-contrast scan, which is not counted, then a arterial phase number 1, then portal venous phase number 2, and a venous or delayed venous phase number 3. So these three together combine a triphasic scan.
So good that you have mentioned the word delayed. Now, if we talk about delayed, what exactly is the delay in which we should be advising, or it should be properly done?
Okay, then arterial scan. I first start with the arterial scan. The arterial scan should be taken after around 35 to 45 seconds after giving intravenous injection. The portal venous phase starts around 70 seconds after the contrast injection. And the delayed scan can be anything delayed than 2 minutes. The count time will be from giving the injection. After that, you have to wait for 2 minutes and then take the scan. This is the delayed scan. Now, sometimes late delayed scan are required. This is not particularly important in oncology, but in hemangioma, hepatic hemangioma, or something like in that lesion, we have to take a more delayed scan at 5 minutes or 10 minutes.
Okay. So, Kaushik, I guess it's time for you to, upload share your screen for the images.
First,
yeah, Kaushik, go ahead.
First, I just want to show just one graphical image to understand the hepatic segmental anatomy. Now, from radiological perspective, hepatic liver is divided into 4 segments. Above the portal vein are 4 segments, that is number 2, 4A, 7, and 8. Below the portal vein, 4 segments, 3, 4B, 5, and 6. Now, above portal vein, the right hepatic vein, middle hepatic vein, and left hepatic vein, these 3 hepatic veins divide the 4 segments. Right to the right hepatic vein is the segment 7. Between the right hepatic vein and middle hepatic vein is segment 8. Between middle hepatic vein and left hepatic vein is segment 4A, and left to the left hepatic vein is segment 2. This is above the portal vein level. Below the portal vein, left to the left hepatic vein is segment 3. Between the middle hepatic vein and left hepatic vein is segment 4B. Between the middle hepatic vein and right hepatic vein is segment 5. And right to the right hepatic vein below the portal vein is segment 6. So below the portal vein, if we think in a clockwise manner, then it will antero-inferiorly is the segment 5, postero-inferiorly is segment 6, postero-superiorly is segment 7, and antero-superiorly is segment 8. And between middle hepatic vein and left hepatic vein, dividing the portal vein is superiorly segment 4A, below it is segment 4B, and left to the left hepatic vein is segment 2 and 3. Now, if we trace this in a contrast CT image, first we have to identify the hepatic veins in, if you can see my screen, this is the non-contrast scan. Then we take an arterial phase.
Kaushik, we cannot see anything, I guess. I don't think your screen is visible, maybe.
But I have opened the screen sharing option.
Just check. Maybe my is slow. Devanjan, can you see what Kaushik is sharing? I mean, the radiology.
No,
Yeah, now it's
right
it's
now,
fine.
right now it is
Now
visible,
it's
sir.
visible. Yeah,
Now
Yes.
it's
now it's
visible.
visible.
Okay. Oh,
Yeah.
so the graphic image was also not visible.
No, that was visible.
That was visible. Okay, now it's visible. Okay. Now here is the non-contrast scan. Then we take a arterial phase scan, then a portal venous scan, and then delayed venous or venous phase. Now in venous phase, we have to first identify the hepatic veins. If we scroll the image, okay. So this is the IVC. This is the IVC which is going into the right atrium. Now in IVC, 3 veins are coming from different direction in liver. Most right is the right hepatic vein. This one is the right hepatic vein. Middle is the middle hepatic vein. This one is middle hepatic vein. And this hepatic vein is the left hepatic vein. So left to the left hepatic vein is segment 2-3. Between this left hepatic vein and middle hepatic vein is segment 4A, 4B. Between middle hepatic vein and right hepatic vein is segment 8 and 5. And right to the right hepatic vein is segment 6 and 7. Now to differentiate in superior and inferior plane, we have to identify the portal vein. Portal vein can be identified in venous phase, also in the portal venous phase. This is the portal vein. This is the right branch of portal vein, and this is the main portal vein. Going towards this side, this is the left portal vein. Now, the liver segments which are superior to this portal vein are segment 7, 8, 4A, and 2. And the segments which are below the hepatic, portal vein are segment 3, 4B, 5, and 6, as I have mentioned already. Now, if we look into the arterial anatomy, we have to take particularly the arterial phase scan. Just a second. Okay. We have to trace it from superior to inferior direction. The first branch of the abdominal aorta is the celiac trunk. So this is the celiac trunk. First branch of abdominal aorta anteriorly is the celiac trunk. Now the celiac trunk gives 3 branches. One is splenic artery. This is the splenic trunk, which is going behind the pancreas. This is the celiac trunk originating from abdominal aorta. From celiac trunk, this originates the splenic trunk. Splenic trunk is going posterior to the pancreas into the splenic hilum. And this artery, which is along the lesser curvature of the stomach, this is the left gastric artery. This is another branch of celiac trunk. So from celiac trunk, one branch is splenic trunk, another is left gastric artery, and this artery is common hepatic artery. So from abdominal aorta to celiac trunk, then celiac trunk to 3 arterial branches. One is left gastric, behind the pancreas is splenic, and going towards liver is the common hepatic. Now the common hepatic artery gives one branch. This is gastroduodenal artery, which goes downward between the pancreas and duodenum. This is the gastroduodenal artery, which is going inferiorly. This is the gastroduodenal artery. This is a branch from common hepatic artery. After giving off the gastroduodenal artery, common hepatic artery is known as hepatic artery proper. So this is the hepatic artery proper. And hepatic artery proper divides into right hepatic artery and left hepatic artery. So left hepatic artery, right hepatic artery joins to form the hepatic artery proper. Hepatic artery proper and gastroduodenal artery joins to form the common hepatic artery. Common hepatic artery, splenic trunk, and left gastric artery joins to form celiac trunk, and celiac trunk to abdominal aorta. Next, below the celiac trunk, next artery, this is the superior mesenteric artery. Now from superior mesenteric artery, many branches are there, but for our reporting and imaging purpose, just superior mesenteric trunk identification is adequate. Then we have to go, the important venous anatomy is the portal vein. So this we have to look into the portal venous phase. So this is the portal venous phase. As we all know, the superior mesenteric vein and the splenic vein joins to form the portal vein. So this is the splenic vein. This is splenic artery originating from celiac trunk, and this is splenic vein just beside the splenic artery behind the pancreas. This is the splenic vein, and this dot is the superior mesenteric vein. So superior mesenteric vein and splenic vein joins to form the portal vein. Portal vein divides within the liver into the right portal vein, and this one is left portal vein. This is this regional anatomy in nutshell. Now, what more I can say?
So yeah, thank you, Kaushik. Thank you very much. So what Dr. Kaushik has just said is the very important, vascular anatomy around the hepatobiliary parts. And remember, yeah, the celiac trunk, the superior mesenteric artery, the portal veins, these are very, very important vascular structures that has been defined in pancreatic malignancies regarding their resectability. We won't be discussing that today. So as we will be discussing only the hepatobiliary part of it. Now, the problem is whenever there is a hepatobiliary pathology, whenever there may be an intrahepatic cholangiocarcinoma, or maybe there is a primary hepatocellular carcinoma, sometimes patients present to us with obstructive jaundice, and that obstructive jaundice is majorly because of obstruction of the biliary outflow. So maybe that is where it's very important for us to understand the biliary tree. So Dr. Kaushik, can you please give a brief outline of the biliary tree, biliary drainage part?
Sure. Now, the biliary tree is somewhat similar to the portal vein. Just first we have to identify the common bile duct. If you can appreciate, this is the duodenum, second part of duodenum, and within the wall there is a tiny hypodense dot. This is the ampulla of CVD, and then I am tracing this hypodense dot. This is CVD, common bile duct, in cross section going through the pancreatic head, and then common bile duct divides into right hepatic duct, left hepatic duct, and further right hepatic duct and left hepatic duct divides into anterior and posterior duct and intrahepatic biliary radicals. Now, if they are not adequately dilated, then I can't show properly them, but if you can appreciate, these hypodense, this is mildly dilated in this patient, already drained by bilateral PTVT. So these are the intrahepatic biliary radicals. From left and right, these intrahepatic biliary radicals joins to form the right and left hepatic duct, and then this right and left hepatic duct joins to form, this is the CVD, and CVD goes down near the ampulla. It joins with the main pancreatic duct, which, if you can appreciate this hypodense line, this is again, if not dilated, you can't identify always, but this hypodense line is the pancreatic duct. So this pancreatic duct, this is the pancreatic duct, this hypodense line, this line. So this pancreatic duct and this dot, this pancreatic duct and common bile duct joins to form the ampulla in the medial wall of second part of duodenum to drain into the second part of duodenum. Now, depending upon where the level of obstruction is, there is Bismuth classification in Klatskin tumor, that is hilar cholangiocarcinoma.
So we would not get into the intricacies of that Bismuth classification. Sure. So it's very important for us. You have already mentioned the different phases of the CT scan that we do. Sure. Just for our residents to understand, can you please tell us what is the washout patterns of these tumors, the hepatobiliary tumors?
Okay, then the major hepatobiliary tumors which have characteristic washout pattern is one is hemangioma, which is particularly a benign lesion. Then is the hepatocellular carcinoma. Then is a cholangiocarcinoma, and These three has typical characteristic appearance, which are without even biopsy or FNAC, we can say this is this. Hemangioma usually they show a delayed contrast enhancement, and the enhancement pattern is typical. First, in the arterial phase, they have a peripheral nodular kind of enhancement. With progression to portal venous phase and venous phase, this peripheral enhancement goes from periphery towards the centra, that is the centripetal flow. From peripheral nodular, the typical description is peripheral nodular discontinuous enhancement in arterial phase with progressive centripetal fill in portal venous and delayed phase. This is the hemangioma. And hepatocellular carcinoma will be typically getting supply from hepatic artery. So they will be hypervascular or vividly enhancing on arterial phase. And as they are getting supply from arterial phase only, less commonly from portal venous phase, so they will be wash out in portal venous and delayed phase. Metastasis can be of different type. They can be according to the primary, it differs. If in a thyroid or in a renal primary, they are typically hypervascular, so they will get enhancement on mostly in early arterial phase or early portal venous phase, and otherwise they may be hypoenhancing. And one more thing characteristic is the cholangiocarcinoma. Cholangiocarcinoma has the typical feature of delayed enhancement. In arterial phase or portal venous phase, they are likely hypodense with the rest of the liver or that, but in delayed phase, they will retain contrast because of their fibrous component in the tumor. So they will be showing delayed enhancement in cholangiocarcinoma. These are typical. Other FNH and hepatic adenoma, they vary, they overlap considerably, but these three are typical.
So that is what, it's very important for all the residents to understand that we should not straight away jump into a biopsy or an FNAC for these hepatobiliary lesions. If the triphasic CT characteristically mentions the washout patterns, remember in hepatocellular carcinoma with a raised serum alpha-fetoprotein levels and a characteristic washout pattern of the tumor, then you don't even need an FNA or a biopsy to start off your systemic therapy. And so is the case of a cholangiocarcinoma, because eventually, if it's operable, they without a biopsy or an FNA, it goes straight away to surgery. Remember, at the end of the day, these are extremely vascular tumors. So these class of tumors belong to those lesions. It might be asked in your final vivas also, wherein we are safe off to start off your treatment without an FNA on paper also. So I guess everybody will be agreeing with that with me. And now, thank you, Kaushik, for all that you have shown. We don't have much to discuss on this. Maybe we can take a few questions before we go on to the next topic of conformal radiotherapy planning. So please, we invite questions from all the delegates who have joined in. Your questions, please. Devanjan, you can start taking the questions.
Sir, right now there are no questions in the QA box.
Okay.
Junior residents, please feel free to ask any questions or write the question up in the chat box right now so that we can take it up.
So because this is not something that we get day in, day out in our clinical practice or in our OPDs, but remember, with each passing day, with each passing year, the role of radiation therapy in hepatobiliary cancers is rising. So please do not ignore to understand hepatobiliary pathology. Okay, it's very, very important. Hepatobiliary radiology, hepatobiliary, pathology, the planning and all, it's extremely, extremely important. So don't be afraid to ask a question. We have a radiologist with us. He will very well take up your question. Maybe we can.
Yes, Dr. Bharat has asked one question. He asked us to differentiate between the metastasis and HCC primary.
Okay, sure. Now, if it's a solitary, usually metastasis, a solitary metastasis is less likely. The common point, sir. Usually, a solitary metastasis is less likely, and there will be multiple lesion, but the typical imaging feature which will help to differentiate us an HCC from metastasis is the typical arterial phase enhancement of HCC. No METs is that much hyper enhancing on arterial phase and will show a delayed enhancement. The HCC will show arterial phase enhancement and it will be wash out in the portal phase itself, but a metastasis will usually not show a washout in portal phase itself. Some metastasis like metastasis from RCC, as I have already mentioned, metastasis from RCC and thyroid, they are typically hyper enhancing, so they will be hyper enhancing, but not as typical of that they will enhance only in the arterial phase and will show washout in portal venous phase. Not as such. And of course we have to consider the clinical scenario and all. And if we trace arterial phase scan in HCC, we can very well demonstrate the arterial stalk which is giving supply to the tumor. From celiac trunk, as I have already showed, the common hepatic artery and right hepatic artery, left hepatic artery, will most of the time, in 99% cases, will be able to demonstrate the arterial stalk which is giving supply to the HCC primary. But in metastasis, we will never find the arterial stalk arising from a hepatic artery to supply the tumor. But in HCC, we will be definitely able to demonstrate the arterial stalk.
Thank you for the very nice explanation, sir. Dr. Abhay has asked another question. He asked us to mention the phases in a triphasic study. Sir, do you want to go through that again?
Yes, I have already discussed. This is nothing. The arterial phase, portal venous phase, and delayed phase. Arterial phase is 30-45 second scan. Portal venous phase is around 75 seconds. Delayed is usually after 2 minutes of giving the contrast.
Okay.
Thank you, sir. Should I go ahead with the next session, sir?
Yeah.
Sure. Thank you for the lucid discussion, sir. Now I would like to welcome none other than Dr. Shirley Lewis to start with her session on the overview of conformal planning in hepatobiliary malignancies. Ma'am is an associate professor in the Department of Radiotherapy and Oncology in the Manipal Comprehensive Cancer Care Center in Kasturba Medical College. Ma'am, please go ahead.
Hello, very good evening to all. At the outset, I would like to thank the AROI West Bengal chapter, all the secretary, president, everyone for this wonderful opportunity. At the same time, I would say this is a great, wonderful learning opportunity for residents. I think we never had this, but now there are so many avenues for residents to make the best use of this, right? I think I'm a host and I'm going to share my screen now. Am I audible and is my screen visible to everyone?
Yes, ma'am. Yes, ma'am. You are audible and visible.
Okay. So today we're going to deal with a very important topic where we are going to discuss about the radiotherapy contouring and a bit on planning for hepatobiliary cancers. So the scope of my presentation today, I would mainly go into what are the indications of radiotherapy for hepatobiliary malignancies. I know anatomy has been dealt with. I will probably just brush through that area. What are the requirements for a pre-simulation audit or assessment? Go on to target delineation, a bit on those constraints, plans, and then we may look at few examples. So we all know that hepatobiliary cancers, they are one of the top 5 cancers, and HCC per se is accounting for almost, it's a third leading cause of death. HCC and liver mets may be much more common among the hepatobiliary when compared to others. However, I would still make a mention here that the biliary tract cancers are very common even in India, especially in the northeastern part. So very much in West Bengal, you may be seeing many more cases of cholangio and gallbladder. Now, radiotherapy so far has made a headway in HCC and liver metastasis to a great extent. We have a lot of prospective studies and SPRT is probably very much indicated in HCC and liver metastasis. However, in cholangio and gallbladder, a lot has been done on systemic therapy, and radiotherapy role is not clearly defined. It's not zero evidence when I say not clearly defined, but I would say that there is lack of lot of prospective studies and of course no randomized studies proving the benefit of radiotherapy. But as we're not going to discuss more into what are the nitty-gritties or the evidence for this, but we do end up treating a lot of cholangio and gallbladder cases because in majority, almost 70%, local progression is a major factor. So let's go through indications for radiotherapy. So as per for HCC or for liver metastasis, these indications mainly hold good for SBRT or hypofractionated radiotherapy. For HCC, radiation would be applicable across all stages, particularly as an alternative strategy to TACE and RFA. We now have probably level 1 evidence in the presence of portal vein thrombosis with the publishing of the RTOG. Of course, the full paper is still awaited. However, as I mentioned, across the different, right, from as a bridge to transplant, early stages 0 to B, even oligometastatic or palliative RT, there is role for radiation in HCC. In liver metastasis, again, as a radical treatment as SBRT. In cholangiocarcinoma or gallbladder, most common indication arises in an adjuvant setting because surgery would be the main common indication. And following surgery, what could be the indication? It could be T2 to T4, margin positive disease, R1 or R2, gross residual. In extrahepatic cholangio, very commonly it happens because there's a lot of microscopic disease spread along the ducts or presence of node positive. I've highlighted the trial which actually shows benefit of radiation in this case, the SWOG trial. In definitive cases, maybe in locally advanced unresectable cases, because standard of line is chemotherapy, so and the most likely mode of spread is distant metastasis. So residual after chemo, or if they are locally progressive. In case of IHCC, you have the NRG-GI1. Unfortunately, it closed very early, but it's a very good protocol for people looking to radiate the IHCC. So most common scenario in definitive setting would be where you may have given 3 or 4 cycles of chemotherapy, reassessed, it's M0, non-metastatic, still localized, non-progressive. You can consolidate that response with radiation and concurrent chemotherapy, followed by further chemotherapy. In neoadjuvant setting, may not be much in our country, but in the Western setting, cholangios, particularly the hilar cholangios, Mayo protocol has been very much standardized. Phase 2 studies from Massachusetts General as well as a lot of contribution from Princess Margaret routinely practice cholangiocarcinomas, hilar cholangiocarcinomas with neoadjuvant CTRT followed by transplant. However, you have to be cautious because they're very, very high volume centers, number one, as well as the size of the tumor is really small, maybe less than 3 centimeters with absence of any nodal or distant metastasis. However, in gallbladder, you have in the neoadjuvant setting a trial which is running in our own country, Polka GB trial. The entire protocol is available online. You can look into it and it gives you detailed indications. I'm not going to go into those indications, but as a nutshell, it is T3, T4 disease, N+ disease without invasion of GI, but needs to be resectable. So it cannot have encasement of vessels wherein no surgery would likely be possible. And of course, in those setting, also definitive setting where gallbladder is not resectable, you would still can go ahead with definitive RT. And lastly, also palliative symptomatic benefit, whether from the node or the primary, many such scenarios do arise. I'm going to skip through this, not going to talk about functional anatomical classification, but what is very important here is that liver is one such organ which is very intricately linked to many organs. That is duodenum, esophagus, in the upper part, stomach, hepatic flexure, kidney, adrenal. So it is not something which can be taken very lightly because the actual dose that you can actually deliver would be limited by tolerance of all the other structures. And liver has a dual supply, right, with hepatic artery as well as the portal vein. This is important for us because the arterial supply as well as the distant takeaway is from the venous is from the hepatic veins, which drain back into the inferior vena cava. You've already shown this. I'm not going to show again, but you have to remember that the celiac trunk as well as the SMA, the branches, these are something which is really important, particularly if you're practicing radiotherapy to the upper GI structures. Again, representing the same thing. I'm going to run through this. Very important is to remember the porta hepatis, because whether it is gallbladder, extrahepatic, or even very fact of delineation of the CBD, this relationship comes very commonly. It was very nicely shown today that portal vein, hepatic artery, as well as the common bile duct. Remember this, that portal vein is posterior while the other two structures are anterior. Medial one is always the artery and the lateral one is the duct. So if you cannot locate the duct, have a look at the artery in the right phase and change your contrast. And usually the diameter of the common bile duct is anywhere between 5 mm to 1.5. Most commonly 5 to 8 mm is an acceptable diameter. So if you use a 5 mm brush to delineate medial or lateral to the artery, you'd be actually delineated the CBD. This is also important for you to remember. In the biliary tree was already shown, but a lot of time this anatomy doesn't hold good. In about 20 to 30% of the time, there are so many variations in the formation of the bile duct. This also needs to be important. I've just shown this in one of my own cases where, it's so easy. If you've gone through this, the very good source for the residents. Keep looking every single case, keep looking at the liver and try to mark out or identify the different hepatic segments, because these are very useful for you if you keep doing that. This again was highlighted, and this is really very important for you because the simulation scans, it's not just in the diagnostic domain, but also in the simulation scans, you have to acquire the cases in these three phases, whether it is HCC liver mets, whether it is cholangio, for pancreas or gallbladder, you would be doing all of these phases. So easy to understand this, it was shown. I also highlight here late arterial phase because some amount of opacification of IVC comes in, but this is commonly a phase that you may end up seeing at times at simulation too. Now, HCC, just want to highlight here, this is a case where arterial enhancement, and it is not a rim, but it's the center part, and you can nicely see the washout. And if this case, you would see, you can fit it into the Lyride's criteria and see, whether this is really HCC. And in the presence of cirrhotic, as it was already highlighted, you can easily take this as HCC and do not need a biopsy. Very important to also remember the portal vein anatomy and to identify where exactly is the thrombus. Both in HCC as well as in IHCC, presence of thrombosis is quite common. And so whether the thrombus is involving the main portal vein into the segmental branches, subsegmental branches. So we do classify this as VP2, 3, 4, depending upon which order biliary radicals are involved. So more extensive, that is presence of the main portal, would be VP3 and 4. And also sometimes you may end up seeing the thrombus in the vein. It is not in the portal vein, but in the hepatic vein, which are draining. And in these, it may be extending right up to the atrium. So for this, it is very important for you to clearly see the anatomy. Somebody did ask about type of metastasis, and I just want to highlight here that there is hypovascular metastasis as well as hypervascular metastasis, which was already pointed out. So unless you don't do the right phases, you're not going to see them. And you can completely miss the hypervascular if you didn't do the arterial. As you see here, it's not going to be seen at all. Very important to remember, in HCC, a lot of patients would have come to you or referred to you post multiple lines of treatment. So they could have undergone RFA, TACE, or TARE. So there will be residual effects or changes that can be seen in the liver. Very important for you to identify. This is an ablation cavity, and you can see some enhancement in the posterior part here in the MRI. Of course, MRI would be more specific in this scenario rather than a CT to identify that recurrence, because this would be likely an ideal case now for SPRT. Similarly, this is another case post-TACE. You can see the lipidiol accumulation here. Very important to identify this post-TACE, because that itself would be like a marker for your matching as well as contouring. And here you can see that there is enhancement at the edge where the TACE probably was not completely done and there is residue. Coming to cholangiocarcinoma, they can be different variety. You have mass forming, you have stenosing variety, and you also have a sclerosing variety. So here is very important that these are the typical finding that there is delayed enhancement, peripheral dilatation. So along the mass, you will see biliary dilatation and capsular contraction. This is also important for you to see which type of classification. So I won't go into a lot of details, but this helps you identify whether it is resectable or not. This is a very typical case of IHCC. You can classically see the capsular retraction here. I hope you're able to see my pointer, right? Sorry, I should have put the pointer. Yeah, you can see here the nice capsular retraction over here. And you can see that in the delayed, this is the arterial, portovenous, and delayed. In the delayed, the mass of the tumor nicely is retaining that contrast, very characteristic of IHCC. But unfortunately, in hilar, most of the time you don't end up seeing any lesion. You will have seen that this case would have got referred to you following a stent. So all you will end up seeing is stent and some biliary dilatation, and you just cannot see a mass at all. And so in such cases, multimodal imaging like MRI, if MRCP would have been done prior, is very helpful for you to see where the ducts are cut off. This is another case where it is typically mass forming. So here are my arrows. You can actually see that there is a mass, there is a lesion. And this is one of my cases where it was so difficult to actually get a biopsy, and we actually proceeded to treatment without a biopsy since CA19 was very high and very difficult to get biopsy in such cases. In gallbladder, this is another case, 2 cases of locally advanced gallbladder. You can see significant amount of liver invasion. Now, what is so special about liver? Liver is one organ wherein there is significant intrafraction respiratory motion. So motion I'll show in the next slide can range right from 8 millimeters all the way up to 2 centimeters. So if you were to treat based on your routine volumes, you already saw so much about anatomy, right? It's so tough to get the right phases on and to see the tumor. You don't see the tumor, and with a moving tumor, what are you going to treat if you're going to do a 2D planning? So that is why in this talk, there is no role of a 2D planning for HCC, because also other factor is the tolerance of the organs. How much tolerance the organs can actually tolerate, particularly liver, which is a very, very sensitive organ. In olden literature, almost 30 to 50% decompensations have been seen where the liver tolerance was not respected. And as I said, it's poorly visible even on the scan. So if you're not even doing scan, what exactly are we treating? Because even with X-rays, all you can end up seeing is the diaphragm. Nothing else you can get information. So we will be focusing only on 3D based treatments for liver, cholangiocarcinoma, or gallbladder, and that would be the standard of care. No 2D is ever advisable, and it's really important for you to see what is the motion of the lesions. Now, this is one of the papers which clearly shows to you that almost 2 centimeter to almost 5 millimeter to 2 centimeter is the actual motion, which they have assessed by various methods, right? From 4D, Cine-MR, or even from X-rays or fluoro. Coming to, once you have this clear picture, understanding how your tumor looks like, you are very confident, you wish to treat. There are a lot of things that you must keep in mind before you jump to contour. I would say, very importantly, review all imaging. Review every imaging with your radiologist, because this is a huge learning curve. We don't get to see these tumors often. And I would say getting inputs to the smallest bits help in contouring. To a greater extent, it would become very accurate. Also assess the diagnostic imaging to look at type of lesion. In cases where you have already given chemotherapy before, make sure that reassessment scans are in place and they're up to date. So at least maybe 3 to 4 weeks prior to when you're planning radiotherapy. Any duration more than that, like 2-3 months, it doesn't make sense for you to plan based on a scan which is like 3 months ago. You get up to date, because these lesions do not remain localized forever. They will metastasize. So proximity to GI structure is also important. Assess the MRCP, so see the type of block, Look at invasion of organs. We already saw they're very close to GI organs. So gallbladder invading into the duodenum, invading into the stomach can be quite common. And you can also look whether you need further imaging like PET or MR. We'll go into next steps in the next couple of slides where I'll speak in more detail about GI preparation, fiducials, and bleeding assessment. Before that, it's important for you to assess when was the last chemo. Now, this I'm talking in a very generalistic fashion because if patients are gallbladder or cholangio, they would have received chemotherapy if they're in definitive setting or adjuvant setting, because you would add radiation after the chemotherapy. Make sure there is 3 to 4, at least minimum 3 weeks gap between the last chemotherapy and the start of radiotherapy. Concurrent chemotherapy, you're going to consider only when you're doing a conventional fractionation. So if you're doing any SBRT or hypofractionated radiotherapy, there is no role of concurrent chemo or targeted therapy because only adds to toxicity without survival benefit. Check all the markers, up-to-date CBC, the counts, liver functions, tumor markers as well. Always do tumor markers before, after, and subsequent visits. Assessment of child fuse status for cases with HCC. Simple things like creatinine clearance, very important because you're going to do triphasic scans for planning. Younger patients, particularly cholangios, can be very young patients in 20s to 30s. Make sure you have urine pregnancy tests assessed to make sure that they're not pregnant. Prior therapies, assess the status. Pathology review in the adjuvant setting. If there are margins, make sure you have assessed whether they are adequate margins, R1 or R2 status. Sorry. Number of nodes which are involved. And if there are no tissue biopsy, like for example, in cases of cholangio, a lot of times it happens, you have to make sure you take a negative high risk consent from patient that you're going ahead with treatment based on radiology for this. I will also emphasize on a couple of things like gastroscopy or upper GI endoscopy and stent placement, particularly in cholangios. They're unresectable. Favor metallic over plastic because by the time they're receiving chemo, so many episodes of cholangitis, whereas metallic help in maintaining good liver function. Cardiac clearance also needs to be assessed. And while you are deciding to treat, also you should have a mental picture how you're going to position these patients. MRI is a great adjunct. You can utilize all the diagnostic imaging. In view of time, I think I will not rush through all the features, but this is a case of METs where you can look at main 2 features that you should look at is T1 and T2. In T1, you can see that the liver is bright, whereas in T2, you can see that the liver is really dark. This gives you a very nice contrast between the lesion and very useful for delineating the lesions. As you can see here, in case of HCC, you can nicely see the heterogeneous lesion. You can also see the capsular enhancement. On the left, you have the case of metastasis, very nicely a target sign also seen. As I emphasized, review all imaging with radiology because it really helps. Look at for additional imaging, whether you need any MRI or whether you need presence of PET scan to help, particularly in cases of metastasis, so that you're absolutely sure you're treating the right place. Now, this applies whether you're doing long course radiation in 25 to 28 fractions or doing SBRT. There is no difference. You have to ensure that there is at least 3 to 4 hours of fasting status between the simulation and even at the time of treatment. We want patients to avoid carbonated drinks so that there is no increased gas in the stomach or the duodenum. Assess if patients have features of chronic constipation. Would they require any laxatives? You can give them small amounts of water. I will come to that about the contrast because negative contrast is much better, where if you can see water, patient can take some amount of water prior to simulation. That gives you a better contrast between the wall as well as the content to delineate the duodenum. And during treatment as well, we tell the patients in the same fashion. In some cases, now there is no hard and fast rule whether oral contrast needs to be given or doesn't need to be given. Institutional protocols are different and it varies from consultant to consultant. Even at the high volume centers, there are people who do utilize oral contrast, but oral contrast, if you're using because it's high high Z this, and so you, for the calculation purpose, make sure that the electron density is set to 1 by the planner. And as I was saying, negative contrast is much better, about maybe 20 to 50 ml, 5 to 10 minutes before the simulation, patients can drink the water. In most cases of HCC or cholangios, you will either have some clips, stents, or liquid oil, or you might use some fiducials. If you're using meds, maybe inserting fiducials may be helpful. But in most cases of cholangio, you will end up seeing stent. And post-treatment, as I had shown previously, lipiodol is very useful. You don't have to change again the house wheel units for these lesions to set them as 1. Stent is very useful. It's very stable. There is study from our own Indian data by Dr. Veena Engineer, who they've looked at stability of stent and they found it very useful for matching, particularly for the hepatobiliary. Now, in cases of SBRT, it is absolutely mandatory that you do breathing assessment, and then you do make sure that you use some form of motion management strategy. Now, motion management strategy can range from 4D to breath hold or even gating. So you have to be able to assess how the normal breathing pattern is. And if you're assessing for breath hold, at least 15 to 20 seconds, we commonly use a spirometer so to help or teach patients how they should hold their breathing. Take a consent from patient, explain them clearly what are the likely side effects that they're going to be, because these are upper abdominal structures, high risk of toxicity to the GI structures, and especially if SBRT to a lot of other organs like the liver itself to ribs. So you have to be extremely careful about this. And most commonly our workflow is that you will assess the patient in the clinic, you've assessed, you've looked into all those pre-planning considerations, you've done a breathing assessment, explained patient, and then on the day of immobilization, you will see their breathing, you will assess them for motion management, which type of motion management you want to do, and then incorporate that into the immobilization. Now, respiratory motion management can be passive, wherein you take the entire motion into consideration. That is an ITV-based approach where you can't possibly take all the phases of respiration and then come up with ITV or a PTV, or it can be in the form of active, where you treat in a particular phase only. So it could be breath hold, or it could be gating, or it could be synchronization. That means you're doing a lot of tracking and then going ahead with treatment. This would actually even apply whether it is for SBRT or it is for cholangiocarcinomas or gallbladder, because even cholangios and gallbladder at the lower edge of the liver would move as much as how a liver would move. So here it's important for you to take into consideration whether patient can do a breath hold. If yes, go ahead with the breath hold kind of a method. If not, assess the motion. People have done various ways. Most commonly is 4DCT, but you can also look at fluoro just to assess how much of breathing amplitude there is. And our aim is to make sure that we keep that breathing amplitude less than a centimeter, so that your PTV is less than 2 centimeters. These are the two common methods where you have DIBH or DEBH. And 4D is acquired with the help of either infrared markers or with the help of these bellow belts, and you acquire all the phases. Now for holding the respiration, you can either use DIBH or DEBH, but it has been found that DEBH probably is much more reproducible. It's much more closer to the average position of the liver than DIBH. And also this study, you can see here that the variations are the expected PTV margins likely much more with DIBH or compared to DEBH. Similarly, another one with infrafraction motion. Coming to immobilization, you have assessed motion. You are thinking how best you're going to use. You stick on to one method, what you would do with the breath hold, with the 4D. After that, you have to think about which is the best way to immobilize. Now, immobilization is important because even in cases of cholangio or gallbladder with a definitive or adjuvant, a lot of times we are going up to doses of 55 to 57. So it's really important that immobilization is nice and rigid and reproducible from day to day. Simple thing I would say is, arms up here, because we don't want any of the beams to pass through the arms here, because in the upper abdomen region. Simple thing will be to use a knee rest, wing board, a customized back lock, or a mold. In some cases, people have used whole body frame for SBRT, but here I would call on something that you've been doing as an institution and what you are comfortable with. Previously, it was very much shown that you have to use a frame, but people have moved on, and even in places like PMH, they technically don't use a frame or even use any backlock or fit. It depends upon the comfort level that you have with you as well as your radiographers, to what extent their experience and what extent are your margins. These are the common things that you would utilize. A knee rest is very useful, prevents rotation, make sure that the spine is very well aligned and straight. Cases where you can't do a ABC or a breath hold, it may be good to do some abdomen compression, particularly when the motion is very high. So people have used the abdomen compression belts, or there are plates which fit onto the abdomen to reduce the liver excursion. Sometimes even when people cannot tolerate abdominal compression, use of lorazepam helps a lot to reduce the liver motion. And here it's very important to know that you must use it at time of SIM as well as at the time of treatment. And we commonly would use 1 milligram 1 hour before the treatment. Coming to the actual CT simulation, you've decided motion management, you've immobilized patients. Next step is that you would do the CT simulation. So in treatment position, you have to take the target as well as the organs into consideration. Very important. So what should be our scan length? Now it depends all upon what kind of beams you're going to be using. If you're ones to treat with CyberKnife, then I think you must treat larger scan length above and below, because you may use a lot of non-coplanar beams. But if you're more of C-arm or Linac based and you're more comfortable treating coplanar, then you may be doing 5 centimeters above and below. Triphasic scan is a mandatory thing. For SBRTs, your cuts could be 1 to 3 millimeter, and IMRT up to 3 millimeters is very ideal. Some even use up to 2 millimeter. Use whatever technique that you're using, particularly planning MR, everything in the treatment technique. Where not possible, diagnostic images can be used for fusion, but make sure you do a liver to liver fusion so that you can delineate the lesion well. IV contrast, use IV contrast between 1.5 to 2 cc per kg, 5 cc per second. Again, depends upon what bore of cannula you're using and what flow rate you can achieve. Sometimes if the bore is less, you can even go 2.5, but maybe you can choose different threshold what you will use to acquire. I am very comfortable with using an IV bolus tracking technique, because it gives me very accurate phases of arterial, portovenous, and delayed to clearly delineate the lesions and as well as correlate with breath hold. So here in bolus tracking, what we do is people range this from around 50 HU to almost 150 HU, wherein you take a plane scan and then you put some ROI onto the aorta, and once the concentration of the contrast reaches a certain Hounsfield in the aorta, that's when the subsequent phases are going to be acquired. And it's seen that the liver enhancement is much well seen. So that means otherwise, if you don't take it in the right phases, what happens is your liver enhancement is poor. So it's always best. You can see here with the bolus tracking, liver Hounsfield units can reach even up to 80 HU. That gives a very good contrast between the normal liver and the target. People have used to synchronize the contrast with 4D CT, and this is something people have to develop at their own institution. Interested people can look at through the paper. I'm not going to go into a lot details of that. As we said, we talked about which workflow we would like to use. It's 4D or we use breath hold. Talked about oral versus this. multi-phase in breath hold. So as if you're doing breath hold, then it is exhale breath hold. I already re-emphasized that. Which type of scans would you acquire? If it's a CT cholangio, I will actually do all three phases because you'll be able to see the nice changes in the contrast between the phases, which help in the delineation a lot. In cases of gallbladder and metastatic cases, maybe you can restrict yourself to just two phases like late arterial and portovenous phase. That would be really sufficient. And if you're using planning, use a exhale scan. Even when you do a 4D, I would suggest to use the CT50 of the 4D, and then it's very useful to compare that with all the other things that you acquired in the exhale phase. Now, when you have a 4D, this is how you will see the tracing. When you will ask the patient to exhale and hold the breath, and you acquire in that particular exhale method. This is particularly when you're acquiring the triphasic. Later on, the 4D will actually sort itself out. What data set you will use depends upon the different phases. Most commonly, at least inhale, exhale, you will see. In HCC, you could, or cholangiomas, you'll see which phase the tumor is best seen, whereas in METs, probably venous. A planning MR is also very useful. A T1 plain and dynamic, so arterial portovenous delayed, and a T2. If you're not able to get a dynamic one, and if you're doing it on the same day, we usually just go ahead with T1 and T2. There also you can see the difference. And your diagnostic scans are very helpful because you would have seen them before and decided which phase you would like to treat. Coming to contouring. Now, when you have acquired the scan, you must see which phase out of the three phases is the tumor best seen. Choose that phase with which tumor is best seen. And the thrombus is particularly seen in the venous phase the best. If you're not able to know difference between the lesion and the other enhancement, toggle back and forth between the arterial and venous, because only the tumor is going to wash out in the venous, whereas the other enhancing stuff is not going to wash out. So most of the times here, the GTV is equal to CTV. So you don't give a CTV expansion. But there are certain cases, like if there are a lot of, non-tumor vascular thrombi is there, prior taste sites are there, you're concerned there could be recurrence, or adjacent RFA, you're concerned, then you incorporate them in. And also in cases of infiltrative type of HCC, their planning MRI is very useful because even triphasic CT doesn't pick it really well. So in that case, you may, when infiltrative one, you may have more deposits beyond. So maybe give some more 5mm as CTV. This I'm not going in detail, but very useful publication to guide you for delineation of HCC. On the right hand side, you can see here enhancing tumor. That's the orange one in GTV, and then directly the PTV. This is the example that is seen for the thrombus. There is some arterial enhancement here with the proper washout. This is very well identified to be the thrombus. And sometimes, like I was mentioning, all that enhances is not the tumor in case of these cases. There may be a lot of arterial perfusion defect, like in these cases. So very useful for you to look at different phases in the arterial, venous, and delayed and see what's happening. If it is perfusion defect, it will remain like that in all phases. But as if it's the right tumor, it's going to wash out. So that is a very useful key for you to see for delineation. This is one of our own cases where a large HCC, you can see here. This is a lesion in the portovenous phase. This was a very large heterogeneous HCC. We did use arterial, portovenous, as well as delayed, but it was more best seen in the portovenous and the delayed phases, where it showed a nice washout. And so it appears more hypodense when compared to the rest of the liver parenchyma. And here you can see some enhancement pattern also there, but the edges. So you should look at edges, how the delineation looks much better. And you can see how we have nicely contoured the chest wall, all the surrounding OARs in this particular case. And you can see here the lesion is very close to the esophagus. So we have given a PRV to the esophagus. I'll come to that in some bit. Another case of HCC, this is a case which was there in the segment 5. You can see a nice well-defined lesion. This is our lesion which is very close to the hepatic flexure. This is again very tricky case, and you can see here we've delineated the GTV, and we can see here that this is the hepatic flexure right here. So we have done different volumes here. You can see that the pink one is there, there's the red one there, and then there is, I don't know whether you can appreciate, there is one more set of area which is here. So what we've done is we've actually gone ahead with different doses like GTV up to 40, 35 here, and just 30 here at the lower part. Very interesting case. I will also show you later when we were treating how this is very critical for you to keep looking at the OARs, how they move. In cases of cholangiocarcinoma, it's best seen in arterial. Like I said, arterial may be good, but again, venous or delayed brings it out much better because it gives you that contrast between the normal liver versus the lesion. In cases of IHCC, GTV will be very much equal to a CTV. It's very, very similar to what we would see in cases of HCC. Coming to cholangio, I don't practice this a lot, so maybe I don't speak much on this, but important to highlight here that people do treat here with this kind of fractionation, like BID fractionation, elective phase 1 about 45, and phase 2 reaching even 60 to 75 grade to the actual GTV. And so the elective regions include pancreaticoduodenal, porta hepatis, celiac, and SMA nodal regions, which receive 45. And the actual disease with the margin along the ducts receives much higher doses. So you can see the kind of margins that they use for the biliary ducts, because it's very difficult to know how the cholangio is extending. So for the elective, they along the ducts, you will expand it or even up to like 2 centimeters. Whereas the high dose, maybe you may limit down to only 5 to 10 millimeters. I'll show you a couple of cases after this, after telling how we actually go ahead. Similarly, in cases of neoadjuvant gallbladder, you will delineate the primary as well as the nodes. And for the microscopic expansion, this is particularly along the liver parenchyma. You may give about 5 to 10 millimeter. Commonly give about 1 centimeter expansion along the liver to take into the microscopic extent. And most commonly, the nodes that we end up treating is around the porta hepatis, hepatoduodenal, and in these cases, when you're treating the neoadjuvant gallbladder, we don't usually end up treating para-aortic phenol because it makes the volume really big. But we'll come to in the next slides when we are treating in the adjuvant setting, probably we would do that. We've not talked about the lymph node regions before, but this is a very useful classification. It's the Japanese classification where they identify the lymph node stations from 1 to 16. You can look into the classification. It gives you great detail. Here, important to identify few subsets, like here 9, that is along the celiac axis, nodes along the common hepatic artery. Less commonly do we include the left gastric artery, but it depends. Like if it is an extrahepatic cholangio, then possibly maybe including even the left gastric artery lymph nodes. And important is the nodes along the pancreatic head as well as para-aortic lymph nodes. How do we delineate these lymph nodes? These lymph nodes are very intricate along the vessels, very nicely shown here to you today, where they showed you origin of celiac, SMA, and everything. And this is from Goodman et al., where they have shown you how you delineate the portal vein, the one in blue here. Red is the aorta. This is the celiac axis origin, and this is the SMA origin. So it'll be very useful to identify, draw these volumes as vessels, and then given expansion about 5 to 10 millimeter around them to create the CTV node. This is a useful publication. I may agree to it with some extent. Here, I would like to say that there is paucity of literature. There's nothing hard and fast here. A lot of different institutions do little things differently. This is a very good publication people can look into, where it talks about what should be included for an extrahepatic or a gallbladder and which lymph nodes they will use. Again, as I was highlighting, hepatoduodenal, left gastric, common hepatic, all of these are in the same region around the celiac region, especially in extrahepatic cholangio. But here, some people, like in the Western literature, they don't commonly treat the para-aortic because, as you would retain, I mean, the AJCC clearly says that para-aortic is an M1 disease. So it cannot be included as a regional lymph node. But at the same time, a lot of recurrence patterns of gallbladder as well as cholangio have shown that so many times para-aortic is the most common nodal recurrence. So I would say, why not? We should probably treat the para-aortic. There is no clear consensus on that. This is the publication showing how they've created expansion for the vessels and then bullion them all together for the nodal CTV. Similarly, for a gallbladder case, along the hepatic direction, they even may go up to 2 to 2.5 centimeters because this is unresectable gallbladder cases. And again, the same set of lymph nodes that you would involve. You can see the volumes are pretty big here because you want to make sure you've treated a large part of the microscopic disease. In post-op cases, now this is probably much more commoner in our setting where we end up seeing either extrahepatic or gallbladder. They are post-op, they are T2 to T4, N plus disease, R plus or R0. In these cases, systematic reviews have shown benefit of adding adjuvant RT in terms of local control and DFS. So what would you take in this case as your volume? So GTV P or N would be something that possibly would be some residual disease or the area of an R plus disease. You would take the entire area where the pre-op extent was. So look at the imaging, take the clips as well as extension around the pre-op region by 5 to 10 millimeter. And most commonly, the nodes that are taken in are retropancreatic or diurnal, celiac, portal vein, as well as para-aortic. This is a study from AIMS where they have published, they have shown their volumes here. You can see nicely that they've also taken the para-aortic. Let me show you a couple of our cases which we have treated. This is a case of post-op gallbladder, which was T2 and plus disease. We also delineated the porta, the gallbladder bed, as well as this is some collection which was there, the tumor bed region, and we've included the celiac as well as the para-aortic nodes. This is again how you can see our entire region. And here we've given two different volumes where, the tumor bed treats up to 50, whereas the elective goes up to 45. Another case of post-op gallbladder, you can see that the clips are there. You have the liver margin. In this case, we've nicely taken the liver margin here and included the same elective nodal volumes. Some cases you will be surprised that even in the post-op setting, you will suddenly end up seeing a node, and the surgeons do not think they can go back and resect it. So it's important for you to clearly review imaging to see if something new comes up. If you don't do a proper triphasic CT in this case, would you really pick up a node? You won't. So even if you're doing IMART, you may say, oh, long course radiation. You still have to do proper triphasic scan because you'll come up with these kind of scenarios. This is a case of palliative RT, wherein, a lot of these scenarios also come in where metastatic HCCs, patients present with surface lesions, which are very painful. We may treat them with 3D CRT, but at the same time, very important to take the right scans and delineate the lesion well and see what doses are received to the other organs. In these cases of palliative RT to the liver, we don't generally go with a breath hold kind of a thing. You can still treat rebreathing, but make sure that your PTV is nice and big. So at least 1 to 1.2 centimeter PTV. And I usually prefer to treat them with 3D CRT so that there is a nice dose follow-up beyond that what we can treat, and you don't have a feature of a tumor miss. And our PTVs are important here. This is particularly in case of SBRT. Even in cases of cholangios or gallbladder, you can go ahead with breath hold if you can implement them well. Otherwise, do the 4D, identify how much motion there is, and put that as ITV incorporation in the PTV. Please do not modify the PTV in proximity to adjacent OARs just to show that the OAR constraints are achieved. That's not the way to do it. You still will expand it by the right PTV, but you may underdose that part of the PTV which is overlapping the likely PRV to achieve that right balance between the organ tolerance and the treatment. If you're doing with breath hold, be it for long course radiation or with SBRT, our favorite thing is to give 5 millimeter. Given that, we should also look at reproducibility. My residents, I think, also have joined in. They know a couple of times. Reproducible, you feel, oh, one scan is really good. Again, one scan isn't good. We do a couple of scans to see, and then the reproducibility is very bad. So no, then you cannot go ahead with ABC for these cases. Most of the times, multiple phases, even if you take, if they're not in the right arterial or venous phases, like in the 4D, you can't really contour on all phases. In such cases, do a point-based estimation, because you can't do an ITV by contouring and then joining them all together. If you're doing the ITV-based concept, then add that margin directly from the GTV to the PTV. Very, very important, and I will emphasize this again and again, that, unless you draw all the organs, you cannot estimate what doses they're going to receive and what is the likelihood of toxicity in the future. Is it really ever possible to do this if you do it by 2D technique? Absolutely not. And there are so many organs in the upper GI area that, you can easily do harm to the patient rather than helping. So don't even venture out thinking, oh, I'm doing some palliative also, I'm going to do it with 2D. No, I don't think that's really helpful. I would always ask you to do at least a 3D, take nice CT cuts, delineate OARs rigidly, and then look at what doses achieve. Here, I emphasize very importantly about liver contouring. A lot of people go wrong in the liver contouring. People include the porta hepatis as well as the IVC in the liver volume, which is not correct. So you shouldn't include them. There is this guideline clearly tells you how you must include or how you mustn't include. When the part of the caudate moves away, you must exclude out the porta. You must exclude out the IVC. Every inch of liver matters when you're counting the metrics for the liver. So make sure that this liver contouring is really good. Another very important structure which comes with experience is the duodenum. Please keep on tracking the scans up and down to see the course. Duodenum is a C-shaped organ, most commonly nestled along the head of the pancreas. So follow that up and down and you can easily see the difference. And all of these structures, the bowels, very nicely have to be delineated. Even for long course, there's a thing whether should we really give a oral contrast or is it not required? Again, varies, depends upon your institutional practice. Now people are more and more moving towards MR, but I'm going to skip that. Once we've decided our target, we need to finally give it a right dose, right? We have to decide what dose I'm going to give. This is the ASTRO summary for HCC, where it says that if patient is cirrhotic, your dose fractionation most commonly in child A would range between 40 to 50. But if it is poor liver functions, you may drop down your dose to 30. In RTOG study, they have even given up to 27.5 grain 5 fraction. We of course have to see how these patients fared with lower doses, but so far there is no data which tells that for HCC you must escalate. Quite the contrary, for liver mets, it is a must that you must treat with very high doses. So for liver metastasis, you're not doing any palliative treatment. You have to do a proper SBRT. And if you're doing proper SBRT, please choose different fractionation or a fractionation which is above 100 BED for the patient. So it can be various. There's no standard upon which should be used, but use one which is according to that. In HCC, the planning, of course, depends upon what liver dose you can achieve. So the planning path clearly tells you that you start with a high dose, but you try to keep on reducing. So most commonly what we do is the mean liver dose. So if you're achieving the highest dose, you must achieve 13. If not, you keep going on to the next levels, 50 to 45 to 40, 35. If it is not achievable, like 17 also is not achievable, then easily don't do it in 5 fractions, hypofractionate them into 10 or 15 fractions where you may be able to achieve the liver constraint. For cholangiocarcinoma, particularly for IHCC, there is a big phase 2 studies from US where they have actually used hypofractionation. Here I would say a word of caution. A lot of people jump to treat even IHCCs with SBRT of 5 fractions. Unless your patient is stented, you may end up with very bad biliary toxicity, and this patient may come with stenosis or biliary obstruction. So it's not recommended that you do SBRT unless they are nicely stented. If not, favor 15 fractions. If they're purely peripheral lesions, do 67.5. But if they're anywhere coming close to porta, you can't go such high doses. You may have to reduce your dose down because you have to achieve the constraint for the common binder. Similarly, for Hilar, I was mentioning, if it's Mayo protocol, they go with these kind of doses. Otherwise, in unresectable cases, where surgery is not possible, chemo, and then you're doing RT, you have three options. You may do SBRT, but not for extrahepatic. Clearly, we are talking about hilar cholangiomas. And in this case, one may try, provided they are stented. Again, word of caution, you have to be really careful. Otherwise, you'll burn your fingers with development of bad grade 3 GI toxicities in the duodenum or in the hepatic flexure. 15 fraction may be okay, but I usually technically prefer more of a long course or standard fractionation with concurrent chemotherapy for these kind of cases. And in such cases, like you can go ahead with the doses of almost like 52 to 57 in 25 to the GTV, while your elective volumes may be receiving 45 to 25 if they are unresectable. In post-op setting, it's more or less standardized that our dose in R0 would range from 45 to 50. And you may end up giving maybe high dose of 55, 52.5 to 55 based on where that positive margin is. If it is at the distal cholangio, it is close to the pancreas. In the head of the pancreas, you must see what duodenum can achieve, doses you can achieve. Or if it is at the liver margin, again, must see where the organs are. But you can easily try up to 55 for this. In case of palliative RT, our doses can vary, like, 8 gray single fraction per HCC, very useful. HE1 trial from Princess Margaret shows phase 2 trial, extremely good results. Phase 3 results are yet awaited. Very useful to help pain, but a lot of pre-medications also needed when you're giving a higher dose. Otherwise, even safer doses are 218.5 or 1310. Now, if you're doing SBRT, important how you're prescribing, what kind of penumbra you're using for planning, if it is for SBRT. If it is non-SBRT cases, long course, then VMAT most commonly, because you have to get that gradient. I'm not a very good proponent of 3D CRT for this because ability to achieve constraints becomes a great problem, and simple APPA or lateral do not achieve. Some people do try to give multiple fields in the form of anterolateral and try to achieve, if feasible, maybe possibly if you can achieve constraints, but I would say IMRT or VMAT gives you a better differential to achieve the constraints. And you must look at coverage at least 95%, 95 for the VMAT cases for long course. And if it is SBRT kind of cases, then at least you must look for prescription dose to be at least 95% and above, but at least a minimum they say is 90% should achieve the prescription dose. Dose constraints from RTOG are very useful, very elaborate for different dose fractionations. Can look at that. This is our constraints that we've looked at. And very recently now also from the UK Sabre Consortium, they've come up with this. They've actually very nicely summarized the data across the sites and they've updated quite a bit. There are optimal and mandatory constraints for SBRT, very useful. If it is 15 fractions you're using, then the NRG GI 003 protocol is very useful. Again, tells you the different doses that you can achieve. Very critical here is the doses that you can look at: duodenum, small and large bowel, as well as the kidney dose. And these are other optional constraints that it gives. If you're using conventional fractionations like 45 to 55 and 25, then you must look at duodenum doses because this is really important. This is the study based on the study from TMH where more than 200 odd patients, we looked at the dosimetric data and correlated with clinical outcomes. And we saw that for duodenum, when we're treating these kind of cases, whether gallbladder or post-op cases, This very well correlated with the grade 2 and above GI toxicity. And if you're respecting this, so V55 less than 1 cc, V50 less than 4 cc, then your risk of grade 2 and above GI toxicity is about 3%, which is extremely good. Apart from that, again, the guidelines give you these outcome and constraints, and this again from the SWOG study, which again give you the constraints what you can use. Here again you can say more or less they come to the same thing, that max dose shouldn't go beyond the 55. They also give you an intermediate dose level for duodenum, that is between 45 to 54. Don't give 33%, because that low dose splash, larger region of the duodenum, can end up causing erythema or ulcerations in the duodenum. Evaluate the plan for good coverage. This is a typical SBRT kind of a plan where, the fall off is really rigid. I'll show you one of our cases where for SBRT, you can see the pink one here. This is the ring, 2 centimeter ring that we use. And here we prescribe 40 gray to the GTV, while the blue one is a 50% isodose, which is 20 gray. And nicely, you can see that our 20 gray is well within that shell. So what this does is this really avoids the low dose spill to the liver, and then the liver constraints are very well achieved. This is the case where I showed you the post-op contouring, and this is the plan that we achieved. 50 here for this, as well as the elective 45. And here I just wanted to highlight about the duodenum. You can see here that for duodenum, our 45 was just 15% and our max dose was just 50 gray. So we have to be very careful to delineate and look at it. Another case of post-op gallbladder, where we looked at what doses we achieved, and here duodenum actually was receiving 54 max dose, but if I look at 0.5 or 1 cc is just about 52. So as much important as looking at this is also to see how you match and treat it. If every day the duodenum isn't in the right position, that means you're not doing IGRT, you're not looking at imaging. How do you know that this actual good plan translated into the right dose within the patient? So important that you keep looking at the right, at matching and treating them well as well. Another case like the palliative RT that I showed you, liver, which we treated with 3D CRT. You can see the wide margins that we ended up giving. Most commonly, if it is long course, you treat them daily. Don't usually give any pre-medications, but if it is SBRT, we will give pre-medications. I will quickly run through this. Important thing for me to emphasize, use the same conditions and please use daily image guidance. Even cases where for cholangio or gallbladder, when we do escalation like 55 and 57, please do daily image guidance, because then you do not know what's actually happening. And if you can implement ABC for such kind of a things, it'll be better, because then the ITV is much smaller and then the irradiated volumes are much smaller. Here, if you're treating liver, if free breathing, then 4D CBCT is preferred, because more than 1 centimeter, then 4D CT definitely is preferred. I'll show one case where exporting isodoses are very important. This is our own case, which I showed you that time, 40 gray overlapping GI. And you can see at the time of delivery, if you don't do a proper imaging, you can see here, that the hepatic flexure is nicely distended, and the red is our 40 gray isodose. We export the isodose onto the CBCT to check it, and you can clearly see that the this patient was constipated after 2 fractions, and this completely got distended and went into the high dose. So we took the patient out, did not treat, used some bowel regimen, and subsequently we were back on track and things matched well. So keep looking. You should know what you're looking at. You should know which is your crucial, which is your pain point, and that should be the thing that you should be tracking. How would you follow up these patients? You would look at tumor markers. Of course, imaging becomes very crucial. I will always highlight about toxicity. If you don't treat these well with rigid meticulous planning, you'll end up with a lot of toxicity, and then there is no running away from them. So unless you're rigid in your planning, how I emphasized today, the rate of toxicities are going to be much higher. This is the rate of toxicities that are with the best techniques. So if you do not use the best techniques, what's going to happen is that the grade 1, grade 2, and even grade 3 will much exceed that 5%, and this won't be 5% anymore. Give you a few examples HCCs that we treated, a case of HCC with portal vein thrombus. This is just 27.5 and 5, but this patient did really well. Even at 6 months, he had a partial response. It responded, but unfortunately, because of presence of thrombus, he had distant mets and then died due to distant progression. Another case of small HCC. This patient we treated with SBRT 14.5. You can see here the baseline MR, very well defined lesion, but later on in the follow-up, you can see the MR, there is no lesion only seen, no diffusion restriction also seen. Another case of colorectal mets, fairly a bigger colorectal mets, and I was really surprised that even at 2 years, this area remained controlled. But you can see here the lung mets, patient then subsequently failed distally, but never ended up having any liver lesions, and this remained non-avid, smaller size for almost 2 years. So to conclude, I would say, one, hepatobiliaries, especially biliary, may be rare, but certain regions like your own at West Bengal, you may be seeing many more of these cases. Role of radiotherapy needs to be defined, but you will receive so many of these cases because we don't know what exact to do. So that is why we must be ready to treat, but play extreme caution, use motion management, delineation is crucial, and learning curve. Make sure that you have your own flow set up at your department. With this, I would like to end my talk, and I'm happy to take questions. I hope I did not run through a lot, but I have some time for questions, right?
Yes, ma'am. Thank you so much for the detailed and engaging talk. Let us see whether there are any questions from the residents. Ma'am, Dr. Arindam Chaudhary has asked, for oligometastatic disease, is embolization possible based on triphasic CT?
So when you mean embolization, are you talking about TACE, TARE, or are you really talking about SBRT, or is it RFA? What exactly are you talking?
I think he means to be, talking about the arterial embolization techniques. I don't think he is talking about SBRT here.
Exactly. So, oligometastatic setting itself is a very small area in HCCs where people have tried to look at. There are no big series on this, but even in like RTOG triple month study, small proportion of patients were oligometastatic, which got treated with even loco-regional modality. But when you talk embolization, you must think like if there is an oligomet, there is liver and there's one more area, would you be able to treat the other area with embolization? I would use a technique, preferably SBRT, wherein I may be able to deal with both lesions simultaneously, isn't it?
Exactly.
I would be advantageous to treat
Yes, ma'am.
both that liver lesion as well as the MET. Whereas instead of applying two modalities, cost effective as well.
Yes,
As
ma'am.
long as the veins, the arteries are patent, technically embolization could still be done. But yeah, so my answer for that would be, make sure that you treat comprehensively.
Sure, ma'am. There seems to be another question. Dr. Madhavi has asked, is there a role of NSCT-RT in carcinoma gallbladder which is unresectable, maybe due to vessel encasement, in order to make it resectable?
Okay. Thanks, Madhavi. This is a wonderful question. So, when we are talking about unresectable due to vessel encasement, vessel means here we are technically talking about the hepatic artery or the portal vein involvement at the porta, which is the case in case of GB. Now, in these cases, if the surgeons cannot resect it, or if there is, encasement means I think it is full 360. It's not even abutment by about 180. We have in the Polka GB very nice cutout guidelines as to what can be or cannot be. If it's borderline resectable where there is, not a proper encasement, but just abutment, maybe yes, you do NACTRT and then take up a surgery. In these cases, likelihood of the complete encasement reducing and then they taking up for definitive CTRT becomes very less, because the dose that you'll achieve is less, likelihood of post-op complications also will be more. So I think these kind of cases would be more likelihood to be taken up for definitive CTRT rather than any CTRT. There are good publications from TMH where they've recently looked at propensity score, I think comparison between just chemotherapy versus CTRT. Having said that, there can be few case reports where, they've called it out as unresectable. Patient survived for 2 years and somebody still went ahead and saw, and they were able to resect. There's no level 1 evidence here, but this kind of case, I would say, if they've said that this is unresectable, then I'll go for definitive CTRT for this.
Thank you, ma'am, for the clarification. As of now, there are no questions that I can see.
Well, I
Sir?
have, Dr.
Yeah.
Shirley, I have a question for you. Like,
Yeah.
say, based on the indications that you have gone through so nicely,
Yeah.
say, for example, a patient comes down to us, operated outside, say, for example, pathological T2N1 disease of gallbladder. And, if the first thing that strikes is like the patient goes to a medical oncologist, gets 6 cycles of gemcitabine cisplatin, and then the patient is on a follow-up, right?
Yeah.
So that is where, I guess we need to put our foot down, don't you think?
Yes, absolutely. So there is a randomized trial on this ongoing. Happy to say when I was at TMH, I was part of the protocol development for that, wherein we looked at randomizing very same kind of patients to adjuvant chemo alone versus adjuvant chemo followed by adjuvant RT. So we were not talking much about indications, but the SWOG trial very much shows that these kind of cases, be it gallbladder, be it extrahepatic cholangiocarcinoma, post-resection with node positive, there is role for you to add adjuvant RT. So I would say you have to add adjuvant RT, because then local control definitely increases significantly. And as I said, most of the times we also include para-aortics in our fields, right? So the para-aortics also get treated, and para-aortics are one of the areas where they will end up coming up with recurrence after chemo alone. So I am a huge proponent, and I would say yes, if it is T2N1 N plus, T2 above, we should add adjuvant RT for these cases. This is the more common scenario for us, actually. That's why I was showing more of those kind of cases.
So if you talk about adding the para-aortics now, I guess the residents would like to ask you, till what level should we go, or the caudalmost slice of the para-aortic contour?
Yes, so I usually go up to the area of the L1. Do not go below that. So that means L1 would be just where you're reaching up to the renal veins, because below that, then they are purely those para-aortics which are metastatic.
Excellent.
These para-aortics that we're talking about is right from the celiac axis origin up until L1. While you're involving, we went through nicely in the previous radiology, they showed you the celiac and the SMA origin, the para-aortics in that same region, because that is where the highest density of micro metastatic spread could be there.
Exactly. So thank you so very much. I think you have stuck to your time excellently well, and if that is the adjective I would like to use. And the talk has been covered so very nicely, not only for the residents but also for us who are right now in practice. It it has given us a lot of understanding of in-depth analysis of how we should go about planning each and every case of hepatobiliary malignancies. So maybe Dr. Abhishek, would you like to add anything if you're there? I guess he's not there right now. So if that is so, I think, we have one more question from Dr. Rajat. And, what to do if we don't have a 4D CT with us, Dr. Shirley?
Okay, wonderful question. So if 4D CT, so you must have at least some form of motion management with you. Okay, let's think from the metastasis point of view, be it HCC or liver met. I would say a basic minimum essential would be that you must be able to use at least breath. Must at least, if you're not treating with 4D and if you're treating with free breathing, you must be able to use at least abdomen compression methods, so that you can do a fluoro and assess how much is the liver excursion. If your liver excursion falls low, it's very low in a case where it is, less than 5 millimeters or, 5 to 8 millimeters in free breathing with compression, I would say that's fine. You can go ahead, treat it. But if not, then 4D becomes essential. Otherwise, you must have a motion management like ABC, where you are doing active treatment in a phase where you can nullify or take account of the respiration. Otherwise, do not try and attempt SBRT. I'm not a huge proponent of saying do inhale, exhale, and be able to generate, because inhale, exhale doesn't give you the right phase at all. There is no way for you to know whether the inhale is actually inhale or exhale is actually exhale. Patient will
Exactly.
be doing voluntarily, and you will not know, because a free breathing scan is an average. You if you do it on a fast scanner, slow scanner, it's going to be different, and it's going to be different excursions of the liver. So I would not advise you to do SBRT in that setting at all. Out. Now, if we're talking about cholangio, if you're talking about long course chemoradiation, in that case, it's still not yet mandatory, because the doses that we use, isn't it? We are using moderate doses. In those cases, if you don't have 4DCT, I would still say do proper triphasic scans, contour the volumes. But you remember this, when you're generating the PTV, it is not 5 millimeter to make yourself feel better. It will be 1 to 1.5 centimeters supine to account for breathing.
Yes.
And then account for that overlap of the PTV onto the duodenum or hepatic flexure. I have also treated many cholangios where we weren't able, but we give a proper margin expansion over there and still use a form of IGRT to match, see something, to see the stent, match, and then treat it. I hope that answers the question.
Yes, ma'am. Yes, there is another question from Dr. Arindam Chaudhary. It refers to the scenario that we discussed earlier. Will there be any change in radiation dose for adjuvant RT post-adjuvant chemo compared to definitive RT, where there is no residual or recurrence?
Okay, if there is no residual or recurrence, and it's just a plain scenario like Dr. Anupam mentioned, right? In that case, I would say that you can stick to your doses, which are nice and safe, anywhere between 45 to 50. So based on how the tumor was initially looking, you have your pre-op imaging. If it was really invading into the liver, then I would say maybe at the liver edge margin, you can give safely to 50. Whereas rest all the elective nodal and the excess CTV along the liver, you can treat up to 45. So 45 to 50 is what's recommended. 50.4 and 28 if you're using 1.8 gray per fraction. If there is no residual, no R plus, no nothing, that should suffice.
Okay. So thanks a lot. Thanks a lot, Dr. Shirley. I guess, whoever has not attended this class has missed it, and only YouTube recording will only be the only way for them to get access to it. Thanks a lot once again, Dr. Shirley, because I
Thank
know,
you.
getting you and having you in this particular forum has been a privilege, and we look forward to your association further. And once again, congratulations for a very, very successful AROI bid for 2024.
Our sister concern, but we heartily and fully support them in the whole
Yeah,
in the conference planning and other
yeah,
stuff. But I would
yeah,
say
yeah.
I'm indebted to you. Thank you for inviting me, and this is a very good forum to teach and give back to the residents.
Thank you so much. Thank you so much, Dr. Shirley. So with this, we come to the end of this talk, this module. And next week, we shall be coming back with upper GI malignancies, and the details will be later put on in our WhatsApp group. Thank you so much, Dr. Shirley. Wish you a very, very year end. So good night.
Good night, everyone. Thank you.
Yeah. Bye.
Good night, ma'am.